let's start this. I'm excited to kick off this conversation on the vital signs of AI in healthcare, trust, constraints, and impact. Let me call on our moderator to host and introduce the panelists. Divya Ajitsaria is the founder of JustYukti, a brand and communication strategist driving impactful narratives across healthcare, technology, and digital-first industries. She's helped brand navigate the complexity of marketing and regulated technologies with clarity and credibility. Over to you, Divya.
Hi everyone. Thanks so much for coming for this session. I would like to start off with introducing our panelists. A lot of you know Gaurav from before. He's the co-founder and CTO of Dozee. Joining him, we have Pratyush, who is head of digital transformation at Narayana Health. Thank you so much for coming here. We're very happy to have you. Today's session is a bit of an interesting one. So we've all been talking about AI and how to build for AI. However, people forget that in healthcare, it's slightly differentiated. We're not just building for efficiency. We're not just building for scale. It is very, very nuanced. So this session is about the unique role and challenges of AI in healthcare, touching upon the Dozee NH relationship, who are also builder and client. So we see AI in the making and discuss what it took to go into that. So let me begin with Pratyush. Pratyush, when you are representing Narayana Health, which is a hospital, but it is also a creator of AI products, what, according to you, do you believe are problems that are significantly harder to solve without AI? Let's just begin with that.
Yeah, so thanks Divya for giving us the opportunity to speak. For us, AI is slightly nuanced in terms that we are very, very cagey about AI implementation in clinical space. We're not very sure what is the outcome. We're not sure how people are going to perceive it. And we're not sure where does the line end for AI to be a decision support system, and where will it assist in decision making, or will it actually lead to decision making. So we're a little cagey on that. So our approach at Narayana has been to kind of develop the product first on non-clinical side, which is slightly lower at risk. So if it's billing, administration, supply chain, that's where we're looking at call center operations. That's where we're looking at AI implementation for us. And we're also looking at how this entire space kind of develops over the next 1.5 years before we start to take it into space of where to say that, okay, it's going to start assisting doctors, it's going to start assisting nurses or what. So slightly different. We're not taking the traditional clinical approach to healthcare. We are building more and more in terms of how we go ahead and build the solution for everything that is non-clinical, and then only move into the clinical space. I just have a slide which kind of Divya is projecting. We're just trying to show you the entire OPD journey as well as the entire inpatient journey. We've completely built it using the usual platforms that are there, using kiosk, app, CRM, WhatsApp, to kind of say that it's the digital twin of a patient when he's experiencing the hospital. What it intends to cover is that anything and everything that is non-clinical, can I remove manual intervention completely? So if you need billing, I don't need to talk to anyone. If I have to stand in a queue, I don't need to talk to anyone. If there is payment to be done for diagnostic services, I don't need to talk to anyone. If I need a cost estimate and a doctor has advised me, I have enough data in the system to go ahead and give you a rough cost estimate based on the procedure that has been selected, that AI can help us with. If you're admitted in the hospital and you have requirements like my air conditioning is not working, the television is not working, the Wi-Fi is not up to mark, or my food is not hot, you should not be bothering the nurses with it at all. These are all non-clinical in nature. So we want to solve all these non-clinical problems first. It's a combination of AI as well as digitization. So it's a combination of both that we are trying to do, and then the entire process. So our agenda is remove as much as possible intervention which are non-clinical in nature using tech platforms. That's our first thing.
Thanks. Gaurav, switching to you, yours is, remote patient monitoring, continuous monitoring. When you started building it, just back in the day, right? Like, what was the technical and clinical gap that made AI/ML necessary?
Thank you for having me first. Pleasure to be here.
Thank you, Gaurav.
We started thinking about Dozee almost in 2015. We registered the company in October 2015. We were two race car engineers, so not from the clinical background, and I would, in all kind of likelihood, say very naive in our thinking when it comes to healthcare ecosystems. But fortunately, I think the vision that we took at that point of time is still the guiding principle that we have, right? And the vision was, can we build something for human health forecasting, right? In 2015, when we started, AI boom wasn't there, but you always had something like weather forecasting. You would know when a cyclone would hit what coast, at what speed. You can plan things accordingly, right? Why? Because you had a lot of satellite imaging data, right? Probably now Zepto and Swiggy would know when are you going to order your next toothpaste before you know, right? Because there's a lot of data that essentially goes on there, right? But can you forecast human health when somebody will crash, let's say, once they've been discharged from a hospital, they're at home, will they crash in the next hour, in the next week, in the next month, in the next year? So that sort of continuous risk assessment isn't done. And for something as important as human health, it should be done. So our first problem statement was, why isn't it done, right? We have machine learning engineers. We had then also. We had good machine learning models. We have even better now, but we had then also. But what we didn't have was data, right? We don't have continuous sources of human health data. And we looked at the variables that were available in terms of their compliance. Even for young people, they were very low. So imagine like a 50-year-old heart failure patient at home. How many times they're going to charge a variable, put them on, use it regularly? Very low. So we wanted to use AI in collecting data. Can we capture a lot of noisy data? Because the constraint was that if we try to go contactless, if we try to go completely automated, right, or autonomous in collecting data without bothering the subject or the patient themselves, right, without having any intervention required from the patient themselves, we would get a lot of noisy data. And then the role of AI would be to actually help us extract biomarkers even in the noisy data. And then the second thing was, when we have this now, all this humongous data available, one option is, yes, rule-based alerts and rule-based kind of based on the clinical knowledge that we've captured in decades, all of these protocols. But then once we have this humongous amount of data, then the data would guide how early warning systems could be built, right? So actually AI-powered early warning systems, which is still the future someday. It's not completely in practice today. And rightly so, it would be regulated very high. But these were the 2 pointers that we essentially always focused on, was can we use AI to capture data sources that are much more non-obtrusive in nature to the patient, no matter how noisy they are, and can we use a lot of that data to build an early warning system and build that actual human health forecasting models. Although we don't call it human health forecasting, it was just the idea in 2015. But yes, maybe someday.
What I'm hearing from both of you, right, in terms of priority to non-clinical and, just forecasting human health, the one thing that is coming out to me very clearly is that you're not using AI for decision-making at any point. It is very clearly a tool to help humans to decision make. Now, do you think this has more prevalence in healthcare because human lives are involved, or do you think like this will be agnostic across anywhere people are using AI?
So yeah. So we did a implementation with Dozee, and we wanted to go nationwide and implement it across our 2,000 beds, the ward beds that we have implemented. And we started our first implementation with Calcutta, Raipur, and Gurugram. The biggest challenge that we saw is that the moment we moved to Dozee is very, very accurate. It's 98, 99%. It is able to detect code blue. It is able to detect any kind of distress in the patient. But the moment we implemented the system, we understood that from a decision support system, it became the primary decision maker. So what our nurses said is that now the system is already there. The system is alerting. So it is the system's responsibility to always alert us. And if there is any failure that's happening, it's Dozee's problem, not the nursing's problem. So what we thought is going to be a decision support system became the primary source of whether there should be an intervention done or not. So at that point of time, we took a call to kind of take a pause, recalibrate the entire process of how to implement such medical solutions And we want to do it slightly differently now because we don't want to take that ownership or accountability away from nurses and pass it on to Dozee. So that's the reason we're going a little slow on the implementation right now. But just to give you an example, in the first 3 months that we started implementing in one of our key hospitals, I think Dozee detected close to around 27 or 28 code blues, which would have got unnoticed had Dozee not intervened. So it inherently built confidence in the system for nurses, and then they completely relied 100% on the system to do that. So I mean, I was talking to Kashi before we were doing this discussion, and Kashi said that, was telling me an example of Tesla saying that 95% of the driver's accuracy is okay, but 98% accuracy of AI-driven car is not okay, right? So that's how it is. We have to kind of ascertain that when do we want to do this. So we're trying to do it slightly differently. So that's the reason from our own learning, when it comes to extremely critical situations where there is a lot of medical calls to be taken, we want to go a little slow and to see how we, so it's not the technology, how do we set the process right? That's more important for us. Yeah.
So Gaurav, I have, what I'm hearing again is that you have to go slow. This is not like you build fast, you break fast, you learn fast, because like literally it is life and death, right? Also, this is entirely, driven by a lot of restraints. It is, in terms of auditability, you have to be like this. In terms of regulation, you have to be like this. So Gaurav, like when you think about the architecture you're using it, there was one thing you imagined, but all of these real life constraints, how do you believe that shaped your architecture?
It's a very good question, actually. Just to kind of add to what Pratyush said earlier as well, right? I think it is bang on. I think we have to go slow. We have to be cautious. There have to be guardrails for sure, right? And more importantly, in our opinion, the feedback that we essentially take, not just from NH, but around the world where we're deploying this, right? It's absolutely synonymous or in sync, because we have to build that into the product itself, the positioning of it, right? AI is assistive in its capacity in healthcare, and my fundamental belief is, at least for the next 10 years, it will be assistive. And I would actually want, if there was some therapy happening on me, I would want it to be assistive only, right? So my fundamental belief, I 100% agree, in something that is as important as human life, we have to make sure that how do we use technology as a force multiplier and not really a replacement for human touch, because these are very complex systems. Human body is one of the most complex machine ever, and we don't understand a lot of it as well, right?
Of course.
Now, in terms of the architecture bit, as you asked the question, right? It is imperative when we were designing these systems, we've built in models for feedback, right? So it is very, very important that when you build AI, you will have a constrained data set. You can go up to, for example, for one of our biomarkers, we had almost 3 years ago 50,000 data points with gold standard. With an ECG, we had from our vibrations, we got heart rate. So it's 50,000 data points only. Today, I sit on 500,000 data points, right? So in 3 years, we've 10x'd it. And probably next time we meet, we would be in millions over there as well, right? So we always have clinical studies on. So one way to grow that architecture is to keep collecting diverse data, remove all the bias, collect all comorbidities, all possible conditions that are out there, but you still can't cover everything. So you have to key in and make sure that your architecture is open for real world evidence or post-market data. So when we get post-market data from NH or from many deployments that we have done, this did not work properly, right? We should have mechanisms to go back, do RCA, and then change management in AI is itself a big issue. Probably in non-healthcare settings happens more regularly. In healthcare settings has to happen with a regulated framework. And kudos to the regulatory agencies like the US FDA, even ICMR in India have come out with guidelines on how you would deploy these AI solutions, how you would upgrade them as well. So they cannot learn live. It has to be a model that it is done in factory and then we deploy it, test it properly and then we deploy it. Once it's deployed, it's static. It cannot learn live. So reinforcement learning models and anything cannot work in healthcare situations.
That is actually quite interesting to find out. Just speaking of this use case again, right? Like when it came to deploying Dozee within your hospitals, what was the change in process as opposed to, say, a different automation system? Because so far, when we deploy new systems, EHRs, this, that, within hospitals, there is a certain set of guidelines. When it comes to a new technology like this, how does a hospital cope? Also, how do products that are not built in-house build trust within a hospital?
Thanks for asking that, because we are experimenting a lot with outside products right now. So the way it is that you don't touch the existing process. You let the process run as it is. So a nurse who is collecting data every 2 hours or 4 hours continues to collect that data. Dozee gets implemented. Dozee is sending its own set of data. Now once Dozee is sending its data and the nurse is collecting its data, there is somebody who is evaluating to check what is the correctness of the data. The nurse is always asked to enter the data in the system, and we validate that information with Dozee. Now when Dozee throws an alert to us, the nurse goes and checks the parameters with the patient also to see whether those alerts are correlating with the actual patient situation. So we did it for all the parameters that you provide us, which is respiratory rate, heart rate, everything. And when we did this for 3 to 4 months continuously in our main hospital in Bangalore, we reached a 98% accuracy in terms of saying that when the nurse reached the patient in 15 minutes within the time that Dozee had sent an alert, 98% of the time the data was correct. Then we presented this information to our clinical director and the quality team to say this is the on-field report that is there. Based on that, we went ahead and said, okay, the product looks pretty stable. The product has met all the FDA guidelines also. So we'll go ahead and deploy it. Now still we deploy it in a ward setup. We don't do it in ICU because ICU has more advanced monitoring in place. So that's the model. You basically, if you have a new product, you don't touch the process. You let the new product do its own thing, and you validate that data with a existing process that you have. That's what we followed
so
here.
So it's procedural. It's not technical, the
no,
way
no,
you deploy new things.
Procedural. It's absolutely procedural.
Now let's look at some outcomes and what is actually driving demand, right? Not just in terms of metrics like number of code blues, etc., but lived experiences, like what on ground has changed for patients, for clinicians, for operators. I'll start with you on this. Wow, Pratyush. What was the breakup of man hours in clinical versus non-clinical, and where is AI really moving the needle for you?
Okay, slightly. So we're moving the topic from the first one to the second.
We are on to your bots.
Yeah, okay.
That's doing really well. It's on the screen.
Yeah. So as I said earlier also, when I said the context, we're using it more and more for non-clinical setups, right? And what we are trying to say is that how can I reduce the burden of clinical work that the nurse does and use very, very simple applications which can alleviate the problems of a patient. So what we've done right now is that as soon as you get admitted in any of our hospitals, there is a conversational bot that starts a conversation with you. It exactly knows which bed you are in, which doctor you're admitted under, and it says, hi, I am your conversational support system here available. You can reach out to me for anything and everything that you want. As Gaurav was earlier saying about guardrail, the only guardrail is that this is a completely purely non-clinical in nature. So if you go ahead, I want a cup of tea, you said my AC is not working, you say that the television remote doesn't have batteries or whatever, it figures out which department it needs to transfer that particular to. And we have built a paging and escalation mechanism where somebody has to respond to the customer in a fixed time. There is a logged ticket that exists, and the customer, if nobody responds to the customer, it gets escalated to the next level. So all of this is completely built. It sits on top, and we have a LLM which kind of course, we're using the ChatGPT LLM to kind of build this model. That's how it is working right now. The good thing is that it's very well accepted by patients. So in probably a month, we see approximately 4,000 tickets raised in 2 hospitals that we have implemented it in. On an average, the customer is using it 2 to 2.2 times to raise concerns and issues. And for the first time, all of those oral complaints that used to go to a nurse, say solve this problem, no accountability when the engineering team or F&B team came, all that is now getting tracked. So now we have more data in terms of understanding where are we lacking in our services, what needs to be done. And the way we have built it is that once you log out of the hospital or you moved out, if you try to do conversation, it sends you a number saying that you need to call at this number. If you try to raise that I'm not happy with the doctor's treatment, it says contact your nurse who is allocated to you. So it's purely non-clinical in nature. But these are the simple interventions we are trying on non-clinical side before we actually move to more complex problems on the clinical side.
Pratyush, so since Narayana is building and is also a hospital, you have an insider's lens, right?
Yeah.
How does a third-party builder sort of compete with that, and what can they do to, build an edge in healthcare AI?
So in healthcare, the most important thing when it comes to any player is the concern around privacy, data protection. That's the most important aspect. If you look at the Data Protection, Data Privacy Act, which is now going to get enforced, if you look at the principal fiduciaries, the responsibility of data fiduciary, it's very, very clearly explained that as the data fiduciary, you are responsible for holding the data. Any breach, you are accountable. The government has set a slab of 250 crores of fine if there's any data breach. So the way we are looking at every, and in fact, with case of Dozee as well, is that, interestingly, we don't share patient demographics with Dozee. So the only information Dozee gets is a bed number. Because we don't want to pass any data to them. So the way we are doing it is that privacy comes first, all solutions come second. If you can be on premise, we would prefer it on premise. Because of a lot of solutions are now looked at agentic AI or AI, Gen AI implementation, we thought it's better suited to build that entire model internally, because then I am not getting into any security constraints and all. That's the reason these bots are built. But if there is an external technology, the only key concern is either you come on premise, or I'm not going to share patient-specific data with you. That's how we're building any model that we're building right now.
Gaurav, how did your product evolve after hitting like real-world complexities like this, right? Like when we're building, we're all idealistic. I'm going to change this and I'm going to do this. And then regulation comes and hospital requirements, data security. How much do you think it has changed because of those things?
That's one of the reasons I think when I don't think it's true for all founders though, but when a lot of founders start building tech specifically in healthcare, a lot of people don't realize the burden of regulations and cybersecurity and other things. And forget, all of these burdens are doable. A lot of people don't realize the burden of adoption in healthcare, right? And that's why a lot of solutions unfortunately don't take off. I think we've been fortunate with understanding these challenges at the right time. I think it's also good that we didn't understand these 10 years ago, otherwise it would have been a very high mental barrier to enter this. But then yes, as in when we kept entering different phases of our startup, once we had a good technology that was built, now was the time, okay, let's figure out where exactly does it fit. Yes, from a higher level, it makes sense. We can identify deterioration early. We can enable clinicians to take interventions early, but where exactly? Outside the ICU. So is it the post-surgery wards? Is it the cardio wards? Is it the nephro? Is it the liver wards? Where exactly do we fit? So we had to do a lot of clinical evaluation, clinical studies, impact assessment studies. So we invested in that. We had, fortunately, a lot of good people joined us and drove that sort of an charter for us. When it came time, yes, we figured out this is exactly where we give the most amount of value. And if you have to drive adoption, you have to focus on highest value. So this is where we give highest value. Okay, now we have to drive adoption. But what are the barriers? Cybersecurity is a barrier because trust, credibility is an issue. So let's get the best certifications possible, even though they are not mandated, right? So today, Dozee is 27001, SOC 2 Type 2, HIPAA compliance. All of these are in place. We are even going ahead and doing high-tech, high-trust right now in the next 6 months or so, even though it's not required, right? But we're still going ahead on a limb and saying that, okay, we will do more to establish trust and credibility. More of those sort of people started coming in. So it's important to identify these things earlier, at least 6 months to 1 year earlier of when you anticipate that this is when it will become a bottleneck. And I agree with Pratyush, on-prem will be a big bottleneck right now when we're looking at it. So is that the way to go forward? Because when we achieve very good scale with Narayana, I'm sure Pratyush will come back and push me for that. So maybe I can give him a solution that can deploy on his cloud at that scale, right? So then it would be contained within the hospital environments, right? So the key factor there is every stage that you're in, make sure that you're in touch with your customer. If you build only in your office, you will die a very slow, painful death. But yes, if you make sure that you are in, the startup will die. But if you make sure that you're in touch with your customers, you know what is on top of their priority. You keep getting a huge feedback. But it's your ability to sift through, okay, these are the top 3 that will become my barriers and bottlenecks. Solve for them now. Have a temporary short-term solution right now, which was basically transfer just the bed number and that's it. But there will be a time when, let's say, demographics or age, gender and these things will improve the specificity of the algorithm itself. So in that scenario, we will hit that bottleneck. right? And intelligence is knowing that now 1 year in advance. So when we do reach those 2000 beds, I need to have a solution ready that deploys on their cloud, right? So there's no shortcut to it. That's the only solution, that you keep in touch, make sure you prioritize well, make sure you staff your team well, because as founders, we will not be the experts in all of. In fact, I'm not an expert in most of these things that I just said, but my team is, right? So I'm very fortunate to say that my team is there.
Do you think AI is making this more complex for you or simplifying it for you?
I think on a level of both. So when it comes to, see, as I said, AI is very assistive in nature. So wherever we do use AI, we are very transparent with all of our clients. We're very transparent. We open up, okay, this is the data that we've used for training. We've used these comorbidities. So we have a whole list of, a whole report that we kind of take them through and things like that. And then we also show them where there could be blind spots as well, right? So AI helps us in establishing that credibility, doing it the right way, that we are fully transparent, and then this is how we're doing about it. But having a non-AI version also is an important thing in most of the scenarios. And wherever we cannot, like for example, if you have to extract biomarkers out of the vibration, I have to use AI, right? There are significant bottlenecks of non-AI solutions that AI helps us overcome. And how do we prove that? We prove that with humongous amount of clinical data, right? But when it comes to actual clinical decision support system, you need to have both of them go hand in hand, and then it will take its course of time to kind of go from a non-AI to AI as somebody kind of uses it in the field and slowly and steadily builds trust over it.
And I actually now want to look at, sort of a future horizon, right, for your products in particular and also health AI as a vertical. I'm opening this out to both of you. What do you think builders of health AI need to know and keep in mind that we don't usually think of when we're building a product like this? What do you think users of these products, like say a hospital, what do you think the hospital needs to understand before using a product like this?
I don't know, the hospital, I don't know about other hospitals, but Narayana is very keen to use the capabilities that AIs offer. But we are trying to look at it again as if from a lens of non-clinical. So I have listed a few things that we are trying to solve right now. So just to give you a brief, like we receive more than 300,000 calls in a month from call center. We have no way to figure out, we depend completely on that call center agent to identify whether this particular call was related to an appointment booking, diagnostic, or was just an inquiry. Now think about it, it's all opportunity for me, which is a revenue source for me, right? So now we can put an agentic AI on top of it to say that, please identify whether this was an opportunity or whether this was just an inquiry, right? Currently, we depend on the agent to do that. We want to completely automate it to say that, okay, out of these 300,000 calls that we received, approximately 250,000 were related to appointment. Maybe they're not doing the call classification correctly. My entire data set is based on few of the call center agents deciding whether this is an opportunity, business opportunity or not. I want to take that away, that capability away from that and give it to AI. That's one use case. Another is, we have around 8 years of HIS data with us. However, I still depend on a guy who sits and generates the cost estimate for me. Cost estimate is a huge opportunity for me. It's 10 times or 15 times the revenue that I'll generate in OP from a patient, from an IP. Can I give this automatically to the patient? And can I actually access the pool of data that I have, which looks at what is the comorbidity data for the patient, what is the gender, what is the age, what is the kind of patient preference, which is the kind of surgery that the doctor does, and then based on the length of stay, can I go ahead and predict and give a roughly 90% or 85% accuracy to say that your bill is going to range from this to this. If I go ahead and do that, one of the biggest problems that we have is that, these are commonsensical problems that, you'll appreciate. We have our OPDs stacked across 5 or 6 floors, but our entire cost estimation happens on ground floor or in one area. So there's a cost estimate area and there are some 5-6 areas where doctors are doing OPD. Because I'm not able to give a cost estimate as soon as the doctor says that you need surgery or an admission, so many patients do not even come to the cost estimate counter. They simply walk out of the hospital. I don't get an opportunity to even sell my product to them because they're like, I don't know, maybe very costly. I don't want to kind of waste my time. I want to do some window shopping. So I'm not even getting an opportunity to sell something to them. I'm sorry to use the terminology is sell something, but I'm saying
great.
from an opportunity, that's an opportunity for me to actually create value for the patient, for the organization, which I'm not able to. With the help of AI, we want to go ahead and say, oh, the doctor said cardiothoracic surgery is needed, or a CABG or a PTCA is needed. I'm able to say, oh, this doctor, when he does a case for an age group of 40 to 50, with this kind of comorbidity, this is the usual bill value, and this is the length of stay. I can give a rough number to the patient, right? So I'm empowering the patient to take the call then and there itself. Another is very big area for our concern is that whenever we have cash business and credit business. Now in credit business, what happens is that a lot of times the payer commits to you that they will make a payment, but then when the actual payment hits you after 30, 40 days, it's 2% or 3% lesser. And usually the payer identifies, oh, you did not follow the entire schedule of charges that you were supposed to, or we agreed that toothbrush is going to be paid by the patient, but you have charged it to me, or the towel has been charged to me, but it should be charged to the patient. Now, all these are islands of knowledge. We want all this to be done by AI. Understand the entire schedule of charges for a particular payer. You decide what is to be billed, and then tell the billing guy, you have misclassified these two items, classify it correctly, right? And then because we have an EMR implementation which is now reaching approximately 90-95% adoption, we want all our data mining activity. The doctor decides and writes it in the text saying advise admission or advise following tests. We want the system to start generating opportunities out of it and say, oh, there's an opportunity for an admission here, there's an opportunity for an MRI or CT, identify the high value items, feed that information into our CRM, from where it can then be pulled as opportunity, and then we can track whether it's getting converted or not. So these are the kind of use cases. We are looking more and more towards business of what we want to do. There are a few implementations on the clinical side that we have started to function, like we have gone ahead and done the automation of voice to text conversion. The doctor can say while doing an ultrasound, this is the size of the benign, whatever they find out, they can go ahead and define the parameters. It goes ahead and puts it structurally for ultrasound, radiology and all. That's what we've done. And second is, we want to get away, this is a big project that we're working on clinical side, is that we want to get away from this concept of somebody charging the patient for any service. We want the doctors and nurses only to write clinical notes. And based on that clinical notes, the system should be able to pick it up from the schedule of charges, which is the appropriate code to be charged to the patient. Currently, it's a manual process. Somebody looks at the medical clinical notes and then goes ahead and translates it. So these are some of the common problems, and that's where we are looking at Gen AI and agentic automation right now. Once we kind of get our hang around it, that's when we come to more clinical applications of these things.
Gaurav, what do builders need to be looking out for? What are they going to see in the form of Pratyush when they go to sell?
No, but I think whatever he said on the non-clinical side, I think any builder can actually, it will be magic to their ears and they can actually take a lot of notes there. What I can shed a little bit light is on the clinical side predominantly, because we have some experience with that. Anybody who's starting right now to build in health AI needs to get the clinical need first correct, right? Because there are a lot of problems waiting to be solved. And the first recipe for disaster is picking up a problem that is not even a problem, right? Or not up high in the priority chain of clinicians or healthcare professionals who are going to use that sort of a thing. So know your problem, know your users, know your need, basics of everything, right? Which you would do in any non-AI things as well. Now coming to the AI piece of it, once you understand the clinical problem completely, you need to strategize and get data accordingly, right? Because to build a clinical solution, it cannot be built without any sort of data. So let's say you're somebody who's going into building solutions for heart failure, right? And you decide to start that, okay, some technicians manually tagging echo loops or echocardiography loops is something of an issue in terms of clinical validity and time that it takes. So I want to build an assistive solution to them so that it happens better, right? So then you would need to collect a lot of echo loops. You would need to collect a lot of these technicians, see how they tag this, and see the difference between where it should have been tagged. So a lot of these data points will now then go into your modeling and everything else, right? So establishing the SOP around data is very, very important. And then all your good clinical practices, all the best practices to do clinical studies, ethics, everything comes into picture there. The other part to this now is once you have all of this data and you're developing, now you've moved to the development stage, you need to be very, very concerned about some key areas which could be blind spots. So one is definitely bias. A lot of this data could be biased, right? So for example, giving you a non-AI example, during COVID, a lot of issues came with pulse oximeters in Africa, right? Because a lot of these pulse oximeters out there in the market do not work with darker skin tones. They were never built for that, those sort of things, right? You would require a higher power LED to work on a darker skin tone, right? And there were a lot of alerts that were not identified in Africa, and Africa did suffer a big brunt of it as well, right? So bias is a real thing, and in healthcare also, we need to see the base technology that you're using, can you solve the bias for that? Then beyond bias, you have data variability and sources variability, right? So when I said echo, so are you using the oldest machine that is out there in the market? And are you using the newest machine that is out there in the market, the Philips one which cost you 1 crore, and there's another Philips one that cost you only 20 lakhs, right? They both have different fidelity of data that's coming in. So you need to be clear on your sources and other things as well. So there's a lot of hygiene around data that you need to do. And then the biggest portion to that hygiene is you have to be very transparent with your consumer at least, right? Because you need to show them that this is what I've done, this is how I'm improving, and make sure that you have a continuous improvement SOP built into your process, both the data as well as the modeling process of it. And then the last process, or actually the second last process, which is a very tricky process, which is the regulatory framework. You've taken a lot of data, you've built solutions, but now before you go to market, you need to regulate it. This is very tricky because the regulatory scene itself is evolving around AI. So regulators themselves are figuring out, okay, how to handle these things. Yes. Nowadays, there are good clinical or good guidelines from FDA. They have proper procedures and everything. But then it's still a lot of times case by case basis. So you will hit roadblocks with regulators, plan for that. When I say plan for that, founders need to plan additional runways because you may run into those loops, and you would have planned for 3 months for an approval, it may take 6 months, right? And nothing you can do about it, it will take 6 months. No additional...
We're doing a session on this tomorrow, you should come.
So no additional VC money will help you shorten that 6 months to 3 months.
Yeah.
It will take 6 months, it will take 6 months. So make sure that you have enough planning to survive. And then the last bit, which is the most important piece of it, you've got a lot of data, you've built a solution, you've passed it through FDA. Congratulations, you may still fail. 50% success rates. Why? Because adoption fails. There are multiple studies out there. There are multiple people who have published papers around digitization, AI in healthcare. You will build whatever you like in your office, it will fail. So make sure that you listen to your customers on a regular basis and you're willing to make those changes in real time with proper policies and SOPs in place. So be aware of these things. Health AI is very significantly more difficult than other industries, right? You will not face so many hurdles. Probably after space tech, healthcare, I like to say, is the second most regulated industry that there is, right?
It's literally life or death, right?
Yes.
Like it needs to be.
Yes, so there is an opportunity to build. I don't think there is a Google of health AI right now. There is a ChatGPT or OpenAI of health AI right now. I think there is an opportunity for all of us to go there. It's still a vast open industry, but then it has its kind of pain points, right? So be aware and then plan for these pain points is the only advice that I can give.
Thank you. Pratyush, this is specifically to you. Can we just do shout outs for people? Some applications, products that you want to see more of in the healthcare space beyond Dozee?
In the clinical space, you're saying?
Clinical, non-clinical, healthcare, right?
So if I have to say clinical, if there is any company which is able to, or any provider who is able to go ahead and overcome the entire DICOM barrier that I have, which is the integration with a Philips is a different integration method, with a Siemens is different, from with a Mindray it's different, with GE it's different. If there is any universal adapter which can get me all the data from all these systems, absolutely love to have that in our setup. That's the biggest problem from a clinical data collection point for us. So we have explored options where you can read directly the monitor, convert it into data, all those things. So if there is somebody who is reliably able to build that connector for us, which is universal in nature, that's a big yes for us. On the non-clinical side, of course, I mean, we have a roadmap ready. We're happy to share with whoever would be interested to look at it, and happy to work with, of course, in the premise and saying that it has to be on premise and all those regulatory requirements met. Happy to work with as many people as we can. Yeah.
Founders, Narayana Health is looking for builders. That being said, thank you so much for joining us. It was interesting to see builder and user on the same stage at the same time. What is really coming out to me is that, AI healthcare is nothing if you don't build with context. It has to be with context, it has to be a longer plan, and at the end of it, like no matter how much we innovate, it will come down to trust.
Yeah.
Thank you so much once again.
Thank you to Pratyush, Gaurav, Divya for sharing your valuable insights. Gokul, I'd like to call you.